previously with the SATTC Center. That continues, but also to work with the Substance Use Disorder Prevention and Treatment division within MSM and National Center for Primary Care. So we've developed multiple models, but I just want to tell you about this particular model that's related to COVID, but also how it can be utilized in other areas, including substance use disorder. So let me present that model. In the month of July, we were awarded an Office of Minority Health, HHS, cooperative agreement, and its title is the National COVID-19 Resiliency Network. The goal of the network is to mitigate the impact of COVID-19 on vulnerable communities. This was brought about because of the disproportionate impact of COVID on disproportionately impacted communities, or vulnerable communities, which of course includes the African-American community, but it was focused on the African-American community, the Hispanic, Latino, Latinx community, Asian Pacific Islanders, Alaska Natives, and the American Indian communities, because those were the ones that were mostly impacted, but also those vulnerable titles that cross all of our communities. Seniors, those who have disabilities, and those who are incarcerated. So with the grant, there are the cooperative agreement, there are 6 objectives overall. The 6 objectives are: number 1, to identify and engage vulnerable communities. Now I've named those 5 communities, but the other communities that we should go into partnership with around every state, territory, and tribe. So it's not just the state. We have to consider the tribal nations, but also those territories of the United States. Number 2, of course, develop the relevant partnerships within communities to disseminate the network. And this is an active information dissemination network. We know there are barriers to substance abuse, information and education, the buy-in from the community, the same way with the COVID-19. Anything that impacts the behavioral and the physical health of the community, there are barriers, whether it be from mistrust of the health system, public health, or it's basically just from miseducation or lack of education. So how do we overcome those barriers to make sure that we can get our communities into vaccinations, into testing, into services? So it is an active information dissemination network. Number 3, partner with those vulnerable communities, but make sure we're developing the messaging, because the messaging is so important. I mean, you can develop the best messaging, you can put the brochures in the hands of the people, you can give them maps, but do they utilize it, and does it actually help change outcomes? So that's the important part of this. Using technology, and I'll show you a bit of the technology to actually link the community to service, where the rubber hits the road, right? With the substance use disorders, it's all right to know where you can go to get the services, but can we actually get the people into those services? There's a big difference. Actually, can we get community health workers out to the people? Can we get, when it comes to treatment for narcotics, et cetera, how do we actually get the community into the services? So linking to services is important. And then 5 and 6, monitoring that, sharing best practices, but also doing the scientific research to make sure that we're actually improving outcomes with this program. So this particular program, those objectives are shown in this illustration: in identify, engage the communities in need, develop national partnerships, which actually have local outreach to communities, develop that multimedia, culturally, linguistically appropriate messaging for all communities, utilizing community health workers and other resources to link communities to services, including behavioral health, substance use, and social services, et cetera. And then monitor and evaluate the quality, share best practices, and disseminate those best practices. So we're developing a toolkit that will actually impact communities around COVID-19, linking them to services. So no matter where they are in the community, we should be able to locate their zip code, or they could input their zip code or make a phone call, understand who they are within the community, what culture and what are their risks, and then link them to those testing services and care that are within their community. And that's including those social determinants. You know, if you're out of a job, can we link you to job services? Where are the resources for food within your community? If you're uninsured, where are those testing sites? Where can I get those vaccinations? So culturally appropriate, but also looking at health equity and the health equity picture, what's the right fit for that community member who needs those services, whether they're insured or uninsured, whether they have transportation or not. So considering all those factors and linking that community to the COVID-related services. This uses artificial intelligence, intellectual automation, whereas the community will be able to use mobile apps and also a telephone call to basically call in and get directed into services, whether they've just been exposed to COVID-19 or somebody in their family is exposed. What do I do next? Do I go home and social distance, or do I have to go for clinical service? Where are the testing sites? Are there any pharmacies around me? Where are the behavioral health services I may need, et cetera, et cetera. The partnership model is so important as it is when we look at all the modeling. And within this one, within the first year, you can see the numbers that we anticipate having at each level. We are looking for national partners that have a local focus within the community. They're capable of community outreach or connecting with those who are within communities. So national partners, but also state and territories, federal agencies, public health, OMH, and community-based organizations, along with community health workers. We have now over 30 partners that are working among those racial and ethnic groups, and we will continue to have and develop outreach partner relationships with others to make sure we can administer this program. Because the main thing is we think that toolkit I spoke about would be a resource for any community-based organization. So if you're a community-based organization and you're engaging the public, we will provide that research, that technology, whereas your stakeholders can go in and identify where they are and identify those services and have resources to link them to those services. So these are partnership capabilities that are important with any model, that we connect with racial and ethnic groups, with ability to communicate with the community, but also partners who have existing resources that they're sustainable, their sustainability can help sustain the program. So let me just quickly go through the model. So those are some of our partners that we have across the various communities. These are some of the areas we're looking at, but this will be a national program, but initially starting in these high impacted areas. You're familiar with these states that have been impacted disproportionately, but also the various populations, including the incarcerated, that we look to impact with this model. So quickly with the modeling equity, we're looking at this pandemic, and let me read this first sentence. Disasters don't discriminate against individuals because of their racial ethnic background, but health systems have implicit challenges that do. You know, even with substance use, you look at it, it affects all communities, but why does it disproportionately impact our communities? Because the health system does not fit the need of the community. And this is occurring with these pandemics. And as we go into these disasters, pandemics, and these emergencies within communities, the health system has to plan to implement differently and develop specific strategies with those communities, those disproportionately impacted communities, because the needs are different. And that's what this model does. So whether it's with substance use, chronic diseases, we use this PETAL framework where we prioritize, engage, target, and act, and then learn. Prioritize the needs of the communities. What are those communities we need to engage, but how should we engage the community? And that, of course, working with partners who understand the community, but also working with community members to see what are their needs. The old community-oriented primary care model where you might have to take the dilapidated cars off the street, turn on the street lights before you can get anybody to partake of your healthcare system. You might have to help them with jobs. If they're working 4 jobs a day, how can they take themselves to get care or get substance use? If they have a substance use disorder, seek care. If they have to go to work 4 jobs and still have kids to take care of. So that social determinant approach. And then of course, coming down to the point, almost like that PDSA cycle where you plan, but you test your planning, you implement, but once you've reached success, or you're not reaching success, you have to evaluate your plan and then improve upon the way you're implementing your plan. So scientific publications are always important, and these are just some of the publications we've been doing around COVID-19. And this will be available for further information about this. We will have a national webinar in December, really to get more information about the partnership. We're kind of really coming out of the planning stage, going into the implementation stage for the COVID-19. But mostly I wanted to kind of leave it with the model, the PETAL framework. How do you engage communities with models that can overcome those racial biases, that mistrust that we speak about, that is prevalent within our community. One of our partners is Tuskegee University, the bioethics center at Tuskegee University. So, the Tuskegee experiment, everybody's familiar with, and that's really impeding us when it comes to these vaccinations. So let me just leave it there, and I'll stop to share. And Celine, kind of like turn it back over to you.
Yes.
Should I just go ahead?
Yeah, thank you so much, Dr. Mack. I actually wanted to address just a couple of questions that we had. Just right before we get to opening up the floor, again, Ask the Expert is a flip webinar. So Dr. Mack probably talked for maybe 10, maybe 12, 15 minutes. And now the floor will open to you all to engage in conversation and ask the expert, as the title says. And so there won't be any CUs provided as we are giving lessons learned and, kind of just sharing back and forth. We might learn something as a team, ATTC and NCPC, from you all as well. So it's a symbiotic relationship here going on today. So there won't be any CUs provided. We are recording because sometimes we like to get those special guests, and not to say none of all of our guests are special, but when we have something on health equity or implicit racial bias, and especially Dr. Mack being our director of the center, we wanted to go ahead and record. It's still intimate. Anything, can be shared, and we'll try to address it as best we can. But I do see a hand up, Mr. Frank. I will let you lower your hand and go ahead. You can come off of mute and ask, or, comment, or, if there's anything, Dr. Mack, you want him to put back up on the screen. But this is this time for us to be able to do that, and we ask the expert. So thanks, Dr. Mack, for that introduction of laying the landscape for us.
Thank you.
Mr. Frank?
Yes, thank you. I was curious, where in the modeling do you have the direct engagement with people in terms of motivational interviewing? From my experience, I used to work on the Target Cities program in Chicago in the 90s, and we did a lot of the modeling you're talking about, making things accessible, program knowledge and awareness in the community resources. But until you had a way to really sit down with people and help them reflect on the benefits of any kind of change in their life, that really things didn't go very far. And I was just curious about where in your modeling do you think of a motivational interviewing terms of pre-contemplation, because that's the first stage of change, of course. Before you contemplate what you're going to do, you need to even, like window shopping. What's the first thing you happen when you go in a store? And the guy comes up and he says, "Can I help you?" And you say, "What?" "Nothing." "No, I'm just looking," right? So that mode has really been found critical. And when I've taught other agencies how to use that motivational interviewing on service delivery, it seems like once you find a way to do that, to really engage people in the process of reflection on where in their life do they need to enhance their life in some way or another, whether it be COVID related testing. Now we, going to come out with the vaccines at some point. That's going to come up here, not too long before you know it. And all of a sudden we'll all be running around like, well, how am I going to get my shot, or who's going to get it, or all that stuff. But in the meantime, I was just curious, where do you put in the engagement, doctor, on pre-contemplation services, so that you can try to get people to go through, really start reflecting on benefits of changes in their life?
Right. Good comments, great comments, and a good question. And I'll address that with the overall framework. And also I'll just let you know what we're doing specifically with the COVID model. And as you stated, we're looking at that model to sustain it far beyond COVID, to address those chronic diseases that really impact our community. But within this model, whether it's motivational, interviews, whatever methodology you're using comes out of once you engage the community, especially from their needs perspective, but also you're engaging community a lot of times with these grants and these cooperative agreements around a certain initiative. We're going to the community with a scientific model that we're trying to engage the community in to get involved into research. And within that model, you develop your methodologies that you think are best to implement your program or to do your measurement. And that comes within how that model that you choose to utilize with engaging the community, but also measurement and acting upon the data or the data that you're collecting, are the activities that you're doing within the community. Now, with the COVID-19, we're not necessarily doing a motivational interviewing, but what we're doing, we're using formative research to develop the culturally and linguistically appropriate messaging. So there is existing messaging out there now across those different racial and ethnic groups, but we're developing new messaging, first by evaluations, surveys, but also focus groups within communities to test messaging, develop new messaging, and then of course, do an implementation and evaluate the effectiveness of that messaging. So it's called formative research. It's a marketing initiative, methodology around developing the messaging. So that's the model that we see best, that we've tested before with MSM that's been advantageous when it comes to developing new messaging to see if it can overcome those barriers. But I think in summary, I would say when it comes to the overall PEDAL framework that I spoke about, this model is flexible for various methodologies on how to engage, measure, and evaluate within communities.
Thank you, Mr. Frank, for your question.
Yeah, thank you.
Okay, so we don't have any questions in the chat. Anyone can come off of mute. We are at 2:26, so we have plenty of time to converse and engage, ask any questions. Nothing too big or too small. If we can't answer it, then we'll say that. But other than that, we would love to have a conversation. You can come on camera, stay off of camera, up to you. But we would love to hear from some others about anything. I know I have a couple questions on the partner capabilities, which was a really cool point. It was in a little box, but there was some good nuggets in there. And I think Dr. Warren is over bioethics. Ruben Warren. I'm not sure if he still is. He was. Okay, yeah. He's a great partner, especially within bioethics at Tuskegee. So it's cool that they're one of the partners. Anyone have any will the PowerPoint be available? Marcia has asked. I'm sorry if I mispronounced your name. Dr. Mack, are you able to share that information?
Yes.
Okay, so it'll be, since this is being recorded, that will be available with the recording, and it'll be, anyone who registered, it'll be sent out to you afterwards for you to be able to view the PowerPoint. Any other questions right now before I get to probing Dr. Mack? If we don't have any right now, I don't want to push anyone to ask, but I do want to give you all the opportunity to ask as many questions as possible.
Any comments?
Yeah.
Comments are welcome.
Yes, Dr. Mack. My name is Kenneth Polite. Thank you too. I've just gotten a lot out of this. I'm just so interested in the Addiction Technology Transfer Center. I attended a faith-based leadership academy, I believe, over at Morehouse last year. You know, I was there and I just somehow got mixed up, missed the interview. I was very interested, and I just talked to Pamela Lee again today. And you mentioned partnership, and I'm trying to, you know, understand what you mean partnership. I'm a pastor in the Pittsburgh area, which we're not over there right now because of COVID, but I've interacted with that community, Mechanicsville, all around where you at too, at Morehouse there, and offer myself up. I'm a person in long-term recovery. I've been clean 18 years, 5 months, and I've been in 9 treatment centers. I lived in every shelter almost in Atlanta. I went back to school at 50 and earned a bachelor and 2 masters. And I'm writing my dissertation right now on when grown folk become grown folk. It's about maturing later in life, you know, the maturation process, which I believe is a fundamental problem with substance use of disorders. And there may be other fundamental issues there too. But when you mention partnership, you know, what exactly does that entail? I mean, I'm a nonprofit too, you know, right now. So I'm trying to figure out how to engage with Southeast Addiction Technology Transfer Center. So what is the process for that? I mean, I went over to Morehouse a few days ago. They wouldn't let me in the gate because of COVID and everything. So I hurry up and signed up for this lecture. And I just kind of want to know what partnership. And I see Miss Dawn Tyus, I met her over there, and I think Miss Celine.
Yeah, I'm gonna let Dawn answer that question.
Yeah, but I just want to know what's the process of, she probably remembers me because I was so excited about, I've never seen something so in line with what I am and who I am, you know, so.
So thank you for your interest, Mr. Pastor Polite. One of the things that we do have is, of course, you know, is the Faith Leadership Initiative, which is let's have a conversation.
Yeah, that's what it was.
One voice, one mission. So we are, and we will be seeking out additional community partners to join us, because we're in the process right now of sending out an assessment of the needs of the communities of faith. So I think that you would be a great champion for that particular initiative. And of course, Ms. Pam Lee, as well as myself, we have your contact information. So I'll make sure that we send that out to you, because we know that any of the work that we do, whether it's with the communities of faith or any of our behavioral health providers, it's very important that we have community champions. And so that we do see you as one of those, and we will definitely be in touch.
Okay, thank you, Ms. Tyus.
Thank you.
Thank you very much.
Thank you, Dr. Mack.
Yeah,
thank you, Dr. Mack, too.
Yeah, and Pastor Polite, God bless you. Sounds like you've had a long journey, but
yeah,
you are where you are, and keep doing the good work.
Okay.
Dr. Mack, I think Pastor Polite brought up a good kind of question, though, as far as when he asked, like, about partnership. And, when small nonprofits, even when they come to SATTC for assistance, or, like some just really don't know where to get started. And you all have this big opportunity that's, has a lot of national partners. I know in that box what I talked about with partner capabilities, and I don't know if you want to put it back up on the screen, but what are some of those challenging ways of kind of getting everybody to the table, or where did you see that kind of being, where you really had to put your strategy and bring your Avengers out to really make that work? Because it's easy to put a grant together or apply for one, but really bringing it all together takes, kind of a magic touch, in my opinion, from what I've seen.
Yes. I know you and Don can speak to that, but Don just recently went through that. That is a great question, and I want to speak to it from two perspectives. Because there's financial partners and there's non-financial partnership. And you can look at both ends. You can look at the grantee, or the one who receives the grant and is making the partnership, as in this instance, the NCPC has led up this, and we've got the funding, and now we are to make partners. But then you have the partners who are in receipt of funding or non-funding, and they're looking for that partnership, whether it be with funds or not funds. So the capabilities, this is a model. When you are the funded one, or you're doing something that you're funding yourself as an organization, who do you partner with? And what capabilities should they have? So, of course, they have to connect to those racial and ethnic groups or other groups that you're looking, that are the focus of your objectives. You want to make sure they have some breadth, right? Is probably, if you can't partner with but one partner, you definitely want a partner who has a breadth where they can go across maybe all Atlanta neighborhoods, instead of the partner who can only be in one. Not saying they're not valuable, but it's according to your funding and your scope. What is their success and their experience and their ability to communicate with the community? Whether it's substance use, what is their experience with substance use disorder? What has been their success? How well are they known within the community? Do they actually have community outreach? Now, in some instances, there are national partners who communicate with community organizations, but they don't do the work within themselves, or they don't do that work. So you have to see, do you need that type of national partner? Or do you need a national partner that has community extensions? One of them is the 100 Black Men, right? 100 Black Men is a national organization, but they actually do have local program. Their programs are locally focused. Not that they're the only ones who can do that. I'm just using them as an example. But there are other, like for professional organizations, where they have professionals, but they don't do the local work. They know the folks, but can they really follow through to do that work? Now, they may be good for another agreement or grant, but they may not be good for this one. And then again, existing resources are so important when you are the funder, because some organizations, no matter how good the intent is, they don't have the resource to carry out the initiative. And even when you have funding, usually the funding is not at the level where it can take care of all of the needs of an organization you're funding with. So you want to utilize your funding in an area where you have some leverage. So they already have existing resources. But then that's the funded partner. Then there's the partner that what we're calling outreach partners within this grant. So it's not a financial agreement or arrangement. It may be an MOU, but what we're trying to develop is that toolkit that organizations can use. So for instance, the pastor talked about it. If it's not financial relationship with SATTC or the division, but the division develops programs and has federal resources that can develop tools that the pastor can use within his organization. So that is a powerful partnership. It's not all about contracts and money. Now, of course, at some point you do need money. So, but what I'm trying to say is, just to be frank, some folks need money and they can't do the work without it. But some folks look at the resources that you bring and say, okay, that partnership is important. And I'm gonna tell you, for successful organizations, and this is what we've done within the SUPT division and what we've done within the NCPC and MSM, there are a lot of partners that there's no contractual agreement with, but I tell you, they're real valuable when you're applying for a grant to say, hey, this is our partner. And that requires ongoing communications, not just communicating when you need something, but continuous communication with strategic partners. That's not always about finances. So let me just kind of leave that there. But that is a very good question. And that is a big part of the decision-making when you, especially you get funded with these federal grants, because they look at your partnerships. And also, for instance, with this one, we're utilizing technology. But if you propose that you're going to put too much money toward technology, they probably won't fund the grant because they say, well, how is that going to continue in the community after this grant is gone? So you need a technology partner who's going to, you know, basically put some sweat equity in this, you know, maybe cut their cost by 50%, 25%. So anyway, let me just leave that there, and hopefully that helps with your question, and see if anybody has any comments around that.
I actually have a question. I'm gonna have to leave in a second, but my name is Jaria Martin. I'm also a minister, but I'm a prevention specialist based out of Selma, historic Selma, Alabama, where I run 3 federal grants out of the Executive Office of the President. And so we actually have a model we use. It's called the Strategic Prevention Framework. I don't know if you're familiar with it, but we follow that closely, and it's led us to have some a lot of success within the community. I've also participated in the Faith Leadership Academy with SATTC, which was an awesome experience. And I'm always asking the question to the facilitators for the special guests at these events. How can the prevention community, or how can the prevention specialists that work with you, can you just talk a little bit more about the partnerships that you've had with the prevention community, and what role do we play, you know, as prevention specialists in helping the treatment, you know, community and helping the recovery community? Could you just talk a bit about, what role you see us playing?
Don, you want to take that?
So, Jaria, I think because the model, what Dr. Mack them are looking at, they don't necessarily work with the prevention specialists. And because we're primarily treatment, we don't oftentimes work with a lot of prevention providers because we have the prevention TTC. So oftentimes that's why you don't see as many webinars or many Ask the Expert around prevention. But we know that we have Celine and Nikki are working with the cooperative team with MHTTC, PTTC, and that's what we typically house or house those particular webinars at Ask the Experts. So Nikki and Celine, I guess Jaria just charged you all with the task to bring before me to somewhat approve, but we'll work on that. And so, and to be honest, the partnerships that Dr. Mack worked with a lot of time are more national organizations, and then they kind of filter back down into the communities. So they don't necessarily touch the providers, but SATTC does more than anything. And ours are primarily, again, treatment providers.
Okay. Yeah, we will definitely take that charge on. I think there's beauty in the collaboration that Prevention Technology Transfer Center, Mental Health and Addiction Technology Transfer Centers have. And Jaria, I know you're very familiar with the Opioid Response Network, and that's another way where we kind of play all together, you know, and sometimes we separate as cousins with TTCCs. But, you know, I think it's all about, you know, having them play their part and then come together in some sort. So I think it would be, you know, awesome. And of course, Nikki and I are always thinking, bubbling new thoughts about ways for the partnership to work together, especially in the prevention world. Prevention is my baby, since I do have my master's in public health, and that's always, you know, a great, really a source for working and collaborating with treatment and recovery. So I would love to, hear your thoughts or, just share with us. We always have on our newsletters a way to engage where you can submit actual things you would like to see from us. We always have that on our newsletters. It's our engagement survey for SATTC.
Yeah.
I'm sorry.
Well, let me say this, Jaria, before you get off, in relationship to the COVID network, COVID is going across all communities. Mm-hmm. And I think in this case, what we have is a tool for you, right? Because you're going to encounter your constituents or your community members who have substance use disorder. You're going to encounter those who are affected by COVID or either have family members. And in this case, what we want you to do is, if you can get on that national webinar, see what the tool is, and actually you will be able to extend that tool to your community members, because what it does is it's a tool where you don't have to spend that time trying to find resources. So it helps give resources in that area, and it can connect them to services, and you can continue to do the work that you do. So please, we're going to provide this PowerPoint, and the last two kind of gives you our connectivity to the website, and it'll tell you about the upcoming webinar where we will show the tool and how it can help you in the work you do.
Okay, thank you.
And then one of the things I want to say, thank you, first of all, Dr. Mack, for answering the call to SATTC to be a part of this Ask the Expert. But one thing I know that with NCPC, anytime we're discussing whether it's substance use prevention, substance use treatment, or whether we're talking about overall health disparities for any people, primarily ours as African Americans, we just have to understand the importance of collaborating with community partners, irregardless, because it takes a village. Then there are so many different areas that we have to touch, and without community partners, we know that we couldn't do the work. So we are appreciative to each of you, irregardless of whether your communities of faith or prevention or community provider. We know that we need you, and I think it goes bi-directional, that we all need each other to fight and to work for health disparities, to dissipate health disparities. Thank you.
Thank you, Ms. Dawn. Does anyone else? I know we had a couple of new people join and a couple of people leave, but a couple of new people did join. So if anyone has I do have a follow-up to a question, but I would love for someone else to bring up anything, comment, ask another question. Feel free to take yourself off mute or bring yourself on camera, or you can put it in the chat. It's up to you. But we are definitely we got about 15 minutes left, so we have a good amount of time to converse a little bit more with Dr. Mack.
Good afternoon, Dr. Mack, and to everybody. It's definitely a pleasure to be here to learn from you, Dr. Mack. So thank you so very much. And when you spoke about the piece on engagement, I have the honor of being a part of the TTC class standards work group. So when you spoke on engagement, I truly have an appreciation for that, because I find that two things: if you seek to get persons into your program, if you don't appear to take the time to meet them where they are culturally and linguistically, then they don't think that you care enough to take care of them if they participate in the program. Right. And then also, when you talk about medical issues, the social determinants of health, these factors are very sensitive to people. So if they find that you aren't able to talk to them in their own language or their culture, they're not likely to share with you to get to participate in the program or to get all that they need from within the program. So I truly appreciate that is your approach that you take when engaging the participants for this program. So thank you.
Thank you, Nikki. How you doing?
I'm doing well.
Nikki, you must have read my mind, because I was just about
Nikki on the call too. So that's you, PT. Good to see you. Good to see you. No, I think that's right. That prompts something. And of course we're predominantly African American community, and you see our team is mostly African American. We have other ethnic groups, But just because we're African American doesn't mean our message is going to be effective in the African American community, right? If that was true, then we probably wouldn't have some of these problems with vaccination, et cetera, especially when it deals with a predominantly African American academic community. One of the issues I say too is research. We research on communities all the time, research within communities, but that's one of the problems with minority academia, especially at medical communities. We know that only about 7 to 8% of the teachers within healthcare academic centers are minorities. And that's because we do this research every year. We go into communities, but we don't make researchers. We don't have programs that develop researchers. We're not intentional on doing that. So, to Nikki's point, I think also us as community-oriented organizations, make sure that we're training people within the community, as SATTC has done, as SUPT division continues to do. Let's not just jump in and out communities when we have the funding to do the research. Even, I don't care how small you are, let's train the people to do what we do. And sometimes that's a threat to us because it's job security. But we really have to train that each one teach one so that those partnerships become stronger and they become more effective. So we've shown that if the researchers and the clinicians are from those communities, their message, their clinical services are more effective if they're from another community. So partnerships are so important that we develop new partners and that we educate and train within the community. That's the best type partnership.
Thank you, Nikki. I was saying you must have read my mind because I was actually going to get to that point, because the name of this expert is Weathering the Storm through, SUD health equity and implicit racial bias. And so I know this year has sparked a lot of different conversations, probably new partnerships, new projects also as well. Dr. Mack, what do you believe can really kind of really just keep this engine going when it comes to the health equity and implicit racial bias conversation, partnerships, projects? We saw a lot bubble up, emerge, get going, but how, as a man of color, and especially as a health professional of color, how do we continue that momentum, after the dust settles of it being like a hot thing to have these health equity conversations where we couldn't have them before? We could, but they were more uncomfortable before, but now I feel like opening up the door a little bit, especially when there are multicultural groups that are wanting to do the work as advocates and allies and supporters. But when the dust settles and we're back as people of color, how do we keep that momentum going with those partners and, just to keep it going?
Yes, it's a good question. We really have to leverage our resources, leverage these funding opportunities that we're speaking about to develop, the same old thing you hear about, sustainable models. How do you develop sustainable models? It goes back to strengthening the knowledge within our communities. It's just like, you think about, this is not always accurate, but you think about, suppose the community, you jump from 50% of the community being college educated to 75% of the community being college educated to 100% of the community being college educated. Then you have more skill sets within the community that can go out and develop new programming, get those jobs to give resources back to the community. As long as we don't have the resources, sustainable resources within the community, we're always at the beckon and call of those who do. So as you stated, the platform addresses our needs periodically, as now. It becomes a hot topic. But when it's not a hot topic, the people with the resources determine what the hot topics are. Wouldn't it be wonderful if we could determine those hot topics? So part of that is education within the community, building that skill set within the community. We know that education is connected to resources, is connected to health, is connected to the way you live, is connected to your finances. That's just like I spoke about researchers, if we can develop researchers within the communities. So when we get the opportunity and we get the funding, let's strengthen our communities, get sustainable partnerships. But at some point, we have to keep it centralized within the community. And that's what, like with MSM, so we're an academic community that has developed resources that really concentrate on minority needs. And you all who are on the phone, you have community-based organizations that do that. We have to kind of grow that model and partner with each other and get those sustainable resources. Now, that's a general comment that takes a lot of detail and planning and know-how, but that old term, we're gonna have to start doing it for ourselves type thing. That's the only way we get to control the conversation.
Thanks, Dr. Mack. So we got about less than 10 minutes left. I would love for anyone to jump in. I won't call anyone out, but we would love to just anyone to come and ask. Maybe we'll probably get through about a question and a half to 2 questions. It's 2:53. I don't want to hold you all if no one has any further questions. Of course, I could ask questions all day long to probe Dr. Mack on the conversation, but really would love to hear from someone else that has a, comment, question, or just, just asking in general for knowledge about something that we talked about today. Ms. Dawn, I know you came off mute.
Oh, no, I don't have another question. I was just going to say to all of the participants, if at any time you have any topics of interest, please feel free to go to www.attcnetwork.org/Southeast, and you can fill out a form and you can request a topic as well.
Dr. Mack, I have a question. You mentioned the vaccine earlier, like briefly, and you said Tuskegee. So for me, I gained a little more information this morning on the news in reference to the vaccine and what it really is. It was one. I know it's several being talked about, but my question is, given that there are fears within minority communities regarding the vaccine, are there any thoughts on how we should approach that to encourage people to take the vaccine?
Yeah, great question. And, we got the question earlier about the motivational interviewing, and I talked about the focus group and the formative research. That's why that is so important to see what is effective, to, I guess, simplified, to go into the community and ask the community member, the citizen or the non-citizen, what would it take to get you to take the vaccine? What's inhibiting you from getting the vaccine? But also asking that questions with organizations, with health systems, look at it in a scientific manner to see what are the barriers, but what is the messaging that can overcome. And I simplified it by saying you can develop a brochure for substance abuse that is so substance use disorder, Don, get me right, but you can develop that. It could be very effective. It could be well tested, but how do you put it in the hands of the people? And then again, how do you get them to act upon it? So I'm kind of answering your question with a question, but it does require that engagement with the community. Some of it is simple engagement, getting out there, getting the message out, but going beyond that with that mistrust, because really, if you look at it, over 50% of the population said they wouldn't take the vaccine today, whether they're white, black, any other racial ethnic group. You got to look at us in the healthcare. Months ago, I wouldn't be the first one up to do it either. They got one now, is 90%. I think more people will step up, but you're still going to have that mistrust. So to your point, some of that is getting in the community, getting the word out, but some of it is seeing what those barriers are and developing the message, evaluating the effectiveness of that message, and then continue to reevaluate and change it while we continue with those community efforts to get the message out there.
Okay, thank you.
Thanks, Nikki. Dr. Mack, I think we have one more question on the table, and it's from Terry, and they would like to know, how can we start the discussion with our elderly regarding the vaccine?
Yeah, it's kind of this, not the same. All populations are different. We are engaged with, one is to partner with those organizations that deal specifically and have expertise with the elderly, and those memberships that the elderly are part of. But in some sense, the same model. See what the barriers are. We know nursing homes is definitely a big part of COVID and the spread of COVID and the prevention of COVID. So partner with those nursing homes. But even when it comes to substance use disorder, I think in some sense, the same model of engaging, prioritizing the community, which means partnering with those ones that can reach the community, but engaging those communities and really having them be part of your program, not only from the evaluation piece, but also from the implementation piece. Have elderly people to be helping you to educate, implement, and question and things of that nature. So.
Thanks, Dr. Mack.